I'm going to talk about preeclampsia, which is an interest of mine, research interest. I'm not going to be talking about my research today, but I'll be talking about updates in the diagnosis and management of preeclampsia. And the interest for this talk in particular was because of the changes from the American College of Obstetricians and Gynecologists in October of 2013 changed the definition that we use, and it sounds like that's here as well that's adopted those changes. And so why those changes took place, and just review some of those that have happened. We know that preeclampsia in some ways it's very common, some ways very simple, but as we heard from Dr. Pania, can be very complex and women can get very sick. So it's an ongoing disorder that we still don't know a lot about. I don't have any conflicts of interest. Why do we keep changing the definition of preeclampsia? Well, the goal is to find a definition that ultimately results in the best care for moms and their babies and reduces complications. So the first goal of the definition is to identify the disease, looking at signs and symptoms of the disease. You know, what matters, the blood pressure, is it the protein in the urine? And over the years, the definition has changed. We also used to include maybe increase of blood pressure from baseline, or we think of other factors like edema, hyperreflexia, that maybe aren't included in the definition, but as clinicians, we use those symptoms to help guide us. So then access to resources. We use those initial tools, our screening tools, right? They're maybe not 100% accurate, but we look at the blood pressure, we look at the symptoms and decide who needs access to resources. And those resources are the hospital and medications. As Dr. Pania mentioned, the leading cause of death is a delay in treatment for blood pressure and then also a delay in use of magnesium sulfate. We know that the sooner we get these medications to the patient, the better the outcome. And finally, even when we get into the hospital, now we're not out of the woods, we're not completely safe. Things can still go wrong in the hospital. And although we have a good treatment, which is delivery of the placenta, and we can all agree that once we remove the placenta, the patient is on track to getting better, that's not the best case for baby. And we'll have a lot of neonatal specialists here that know that a premature baby has a lot of complications. So it's a balance between maternal and neonatal health. What was the old definition? Hopefully most of us remember it because it was just a couple years ago. That the definition was pretty simple. And we had a simple definition, I think, to make it easier to identify women. That was elevation in blood pressure after 20 weeks and protein in the urine, which initially required a 24-hour collection of urine, and then we said over 300 milligrams in 24 hours. And that was the definition. That was it, pretty simple. And now that's changed a lot. And the reason that we changed that is because this definition may not capture all women that have complications. So many women, for example, won't have the protein in the urine, but will have complications such as seizure that we know are related to preeclampsia. So the definition change really is inspired by a lot of things, our understanding of the disorder over time and research studies. And now we understand preeclampsia really as an inflammatory disorder. It's very heterogeneous, right? It's different in every patient. And it affects multiple organs, many end organs, as we were talking about. So it's different in everybody, heterogeneous disorder. We know that everybody that comes in with preeclampsia is not the same. Some women have symptoms in the brain. Some women have findings in the eye, the liver, kidneys, and then blood vessels. And even within each of these organ systems, the symptoms are different. So in the brain, some women have headaches. Some women will have seizure as the first sign, and some patients will have stroke. In the eyes, some will have blurry vision. Some may have blindness. the liver, sometimes a little bit of inflammation, like on the laboratory tests, and some women will have a lot of pain. The kidney, the proteinuria, but sometimes it's acute renal failure. And in the blood vessels, sometimes it's endothelial injury and the capillary leak, so the edema, the swelling, but sometimes it's the blood cells that are destroyed, the red blood cells, the platelets. And again, we know from patients that definitely we see all of these symptoms, but we don't see them all in one person. We see them differently in different patients. And then those are all the maternal symptoms, but then the baby can be affected, right? So sometimes mom's affected, sometimes baby's affected, and sometimes both. And the symptoms for baby include growth restriction, low fluid, abruption of the placenta, and fetal demise. So when we look at the old definition of just preeclampsia as hypertension and proteinuria, it now seems very outdated. It doesn't seem like a very good definition when we know that all of these things can take place. So as I said, in October of 2013, the American College of Obstetricians and Gynecologists made this bulletin to change the diagnosis, and a pretty dramatic change, a big shift in our understanding of the disorder. And so what is the new definition? Hopefully we've been using it for the past couple years. One thing, just looking at each part of the definition, the blood pressure changes are the same, 140/90, so 140/90, and then 160/110 is for severe disease. But one thing in the definition that was a small point, but is actually a very critical point, is this, that normally we would say if the blood pressure is over 140, we want to make sure that it's accurate, so that blood pressure has to be persistently elevated for more than 4 hours. Well, if your blood pressure is 160/110, we don't want to wait 4 hours. And that did happen occasionally, that someone said, well, I don't know if they have preeclampsia, it hasn't been 4 hours. That's very dangerous, because if the blood pressure is over 160 or over 110 diastolic, that's a hypertensive emergency. And if it's persistent for more than 15 minutes, that's a life-threatening emergency. So now we say minutes apart, and that allows you to treat sooner. So your blood pressure is over 160, 15 minutes, that's diagnosis of preeclampsia and needs to be treated. Again, some people will say, well, there might not be any other symptoms, and it's true. If this is the only thing that you see, then we call that gestational hypertension. But even if it's gestational hypertension and not preeclampsia, this is still an emergency and still requires treatment. So really, it doesn't matter whether it's gestational hypertension or preeclampsia. If you have a severe blood pressure, it needs to be treated. Okay, well, what about the protein? The protein is still the same. So we say now there's less of an emphasis on protein, and that's true. You don't have to have protein, but it's still an important criteria, and many, many women are still diagnosed with preeclampsia based on protein in the urine. The main difference, again, is a small change, but a very important change. We used to rely on the 24-hour collection of urine. Again, someone comes in with elevated blood pressure, we collect the urine for 24 hours, and then if it's over 300 milligrams of protein, we say they have preeclampsia. Now we can use this spot protein creatinine. So we take the urine, we send it to the lab, right? They measure protein and they measure creatinine in a single sample, and we call that the ratio of protein to creatinine. If that's over 0.3, now that's diagnostic of preeclampsia. And many places were using this test before, just now it's supported on a higher level. And I haven't done a 24-hour urine in over 2 years because I do really trust this test. It saves a lot of time because this test comes back within an hour if you have it available in your lab, and this one takes 24 hours. So if I want to manage a patient more quickly, I'd rather use a test that comes back more quickly. Well, what if you don't have protein? oops, let's go back. So now the change that's a little bit bigger, those other changes are small changes. The big change was that you don't have to have protein in the urine to have preeclampsia. So now if you have elevated blood pressure, no protein, you have to look for these other factors. And you have to look for these factors because now they're part of the definition. If you have elevated blood pressure and you have a platelet count that's below 100,000, that's preeclampsia. If you have a blood pressure 140/90 and you have a creatinine that's 1.2 and the person had normal kidney function before, that's preeclampsia. Again, any of these, elevated liver enzymes, pulmonary edema, headaches, or visual symptoms. Now that's really a big change. Also, it means that if someone has an elevated blood pressure and they're in clinic and you dip their urine and the urine is negative for protein, they require more evaluation. They require a blood test, right? Because you have to look at the platelets, you have to look at the liver enzymes. And that's a change because we often would assess patients in clinics, right, outside of the hospital, and if their urine was negative, we felt comfortable manage them outside of the hospital. But now we have to do that extra assessment with the blood tests. So now this is the new definition of preeclampsia. And it's more complex than we had before because now it's, okay, blood pressure, protein, yes or no, and then any of these symptoms. So now it's a more complex definition, but I think it does capture the bigger picture of the disease. Severe preeclampsia, mostly the same as it's been before, with all of those conditions, low platelets, elevated liver enzymes, creatinine, headaches, still defines severe disease. What's really important and was also a pretty big change was the criteria that was removed from severe preeclampsia. So growth restriction no longer defines severe preeclampsia, according to the American College of Obstetricians and Gynecologists. And we may disagree. I partly disagree with that because I think that's a pretty severe condition. And when you put that on top of preeclampsia, we're very worried about the patient. But really, the reason that they did that was because they said, well, the IUGR growth restriction should be managed the same whether you have preeclampsia or not. And we can argue about that, but they felt that the two conditions should be managed separately. And so we've done that in our practice in the United States. The other thing is we used to measure that protein in 24 hours, and if it was over 5 grams, 5,000 milligrams, that we said that's severe preeclampsia. Well, now the American College of Obstetricians and Gynecologists says that the amount of protein in the urine doesn't correlate well with complications. And again, we can argue about that. I agree that someone that has 8 grams of protein in the urine is more likely to get sick. The reason that was changed was because women who have low protein can also get sick. So if you have 200 milligrams of protein in the urine, which is a low level, you can still have a seizure. And so the degree of protein doesn't correlate well with complications. And that's why the decision was made to remove those from severe criteria. Okay, so that's the update in the definition. Now we have a new understanding of the definition. I'm not going to go deep into the different theories of preeclampsia, but I wanted to just have one slide on the lead-in theory of preeclampsia just to understand some of the recommendations. Our thought is that it initiates from the placenta, and we partly know that because when we remove the placenta, the patient gets better. But that the blood supply to the placenta is essentially not as good in preeclampsia from early in pregnancy. That the placenta, when it implants, the blood supply comes from the maternal circulation, right? And then fetal cells, trophoblasts, invade the maternal arteries, and the arteries are remodeled. And what does that mean? That normally this is non-pregnant, that the blood flow to the uterus. And then in normal pregnancy, the blood flow, the vessel opens up because when the fetal trophoblasts invade the maternal arteries, it dilates, and that reduces the velocity of blood flow to the uterus. So you have a large amount of blood flow, but at a low velocity, and that's a healthy pregnancy. But in preeclampsia, the fetal cells don't invade the maternal vessels as well, and what happens is the vessel doesn't dilate. So this would be preeclampsia, and this would be normal pregnancy. What happens with that is that when the vessel doesn't dilate, the pressure remains high. So the flow is reduced and the velocity is high. So that creates injury on the placenta. Sometimes maybe that might result in pregnancy loss early in pregnancy, but sometimes it just builds up over time, and by the second trimester or third trimester, we start to see signs of that placental injury. So we think poor flow to the placenta, inflammation, and these inflammatory factors that get into the maternal circulation, and those inflammatory factors result in high blood pressure and can affect different organ systems such as the brain and the kidney. Okay, so based on that understanding, really there's been a lot of great research, but a lot of it hasn't made it into clinical practice. And I would say particularly in the United States, we haven't adopted a lot of the changes that are maybe adopted in other countries. For example, the American College of Obstetricians and Gynecologists do not recommend uterine artery Dopplers, and they don't recommend any blood screening tests. So uterine artery Dopplers, I don't know if anybody here is using that as an early screening tool, but it is very common in Europe, right, in other countries, to measure the blood flow. Now you're measuring the maternal artery, right, maternal blood flow to the uterus, and you're looking for resistance to blood flow, and it's been used as a screening tool to say if there's resistance to blood flow early in pregnancy, that increases your risk of preeclampsia. The problem is it's not very accurate or not accurate enough for us to implement. So right now, this is not a test we're using to predict preeclampsia. There's also very interesting blood tests like placental growth factor. So placental growth factor is important for a healthy placenta. When the placenta is injured, there's less of it. And in women who have preeclampsia, have very low levels of placental growth factor because their placenta is not working very well. And many providers in other countries have used this test to screen for preeclampsia. And we see news articles and clippings in the news that there's new tests to predict preeclampsia. Again, we're not using this test, and I think it's good in many ways, but there's limitations. And I think it hasn't been proven to be better than clinical assessment at this time. So we aren't using it routinely. Well, if we don't have these fancy tests to predict preeclampsia, we all want an easy test, an ultrasound or a blood draw, but we're not there yet. What do we use to predict preeclampsia? Well, we use something that's old-fashioned, history. We take a history from the patient and we do a physical exam, and these are still very helpful. They're not as fun as some of the newer tests, but we know. While we don't know a lot about preeclampsia, we know predominantly who gets preeclampsia. Women with kidney disease, chronic hypertension, prior preeclampsia, obesity, diabetes. The risk of preeclampsia is 20 to 25%. So 1 in every 4 women with these conditions are going to get preeclampsia, 25%. So we know the high-risk women, and it's important to identify them early. When we look at healthy women, it's only about 5%. So it's harder to predict preeclampsia in healthy women, true, and that's still a very tough challenge. But most of those women will do quite well. And so we don't want to miss these disorders. So screening for diabetes early in pregnancy, screening for kidney disease early in pregnancy. For women that have had children before, asking them about their pregnancy history, and then we could start to determine who's high risk without needing extra ultrasounds. Well, now what if we can say we know who's high risk for preeclampsia? What can we do about it? Can we do anything? And it's very difficult because most women will have normal pregnancies. Even high-risk women, majority will have normal pregnancies. So if we're going to give an intervention, it has to have minimal risk. Again, looking at that, if we take 1,000 pregnancies, and now this is average, it's going to change in a high-risk population, but in 1,000 pregnancies, 925 will not get preeclampsia, 70 will get mild preeclampsia, and 5 will get severe preeclampsia. So if we give an intervention to a lot of people, a lot of women won't need it. And so we have to be very careful. What do we have to prevent preeclampsia? We've done a lot of vitamin studies. So far the vitamins haven't shown benefit, but low-dose aspirin seems to not have a profound effect, but has a consistent benefit for a mild reduction in preeclampsia. So the American College of Obstetricians and Gynecologists in 2013, so the bulletin from 2013, they recommended low-dose aspirin to women with preeclampsia in a prior pregnancy if it occurred early, before 34 weeks, or women who had preeclampsia more than once, so they had recurrent preeclampsia. Well, what's the problem with that? It's good. I mean, that's definitely a high-risk group of women. The only problem, it's a very, very small group of patients. I mean, if you talk about women with preeclampsia before 34 weeks, it's not a large number of women. But we've started this in our practice, and we give low-dose aspirin. We typically give 81 milligrams. Low dose, some debate, but 100 milligrams or less is safe. And I usually start at 11 or 12 weeks. The thought is that really ideally it started at the end of the first trimester. There may be a benefit up until 20 weeks. Once you get beyond 20 weeks, there's definitely less of a benefit. What is the benefit of low-dose aspirin? This is a meta-analysis in The Lancet of all the studies. There's been over 50 studies of aspirin for prevention of preeclampsia. And the conclusion from this meta-analysis is you get a 10% reduction in risk of preeclampsia. A relative risk. So if your risk of preeclampsia is 30% and you take low-dose aspirin, now your risk is 27% because 10% of 30 is 3. So it's not a big reduction in risk. You go from 30% to 27%. So we can agree that it's not a cure, but from a population perspective, a public health perspective, we'll reduce preeclampsia if we implement this strategy. Well, some people say, why not to give it to everybody? It's pretty safe. Again, that debate of, well, a lot of women may not need it. And so how do we decide who to give it to? And why did ACOG choose that group? Well, let's use an example. 1,000 healthy women and 1,000 high-risk women who had severe preeclampsia in their prior pregnancy. Among those two groups, in the first group, 75 women will get preeclampsia, right? 75 out of 1,000. In the high-risk group, 250 out of 1,000. Well, as an experiment, let's give them all aspirin. We're going to give all of them aspirin to start their pregnancy. And you'll prevent a number of cases of preeclampsia. In a healthy population, you'll prevent 7 or 8 cases of preeclampsia. In a high-risk population, you would prevent, what does that say, 25? Sorry, I can't even read it. 25 cases of preeclampsia. So basically, if you give aspirin to a high-risk population, you prevent more preeclampsia for the same number of women. So we look at, in public health, the number needed to treat. How many women do we need to give aspirin to prevent one case of preeclampsia? In a healthy population, you would have to give 125 women aspirin to prevent one case of preeclampsia. In a high-risk population, you'd have to give 40 women aspirin to prevent one case of preeclampsia. And so we just have to make a decision, what is a good number? And I think people agree that 40 is a good number, but 125 is probably too many. Also, healthy women don't really want to take medications they don't have to take, and that makes a lot of sense. So this has changed. Now, breaking news, update. In July of 2016, the American College of Obstetricians and Gynecologists changed their recommendation of who should get low-dose aspirin. And now it's recommended that all high-risk women get low-dose aspirin. So not just women with prior preeclampsia, but women with multiples, twins, triplets, women with chronic hypertension, diabetes, kidney disease, autoimmune disease such as lupus. So I agree with this because all of these women have a risk that's about 20 to 25%. Probably healthy twin pregnancy is a group I'm not as sure about because their risk is a little bit lower. But certainly chronic hypertension, diabetes, kidney disease is a high-risk group, and they would benefit from low-dose aspirin. So now, just in the past month, I've changed my practice to offer aspirin to these women. Okay, so we talked about the diagnosis, prediction, prevention of preeclampsia, and what is recommended to monitor for preeclampsia? Well, one, already, we don't use the term mild preeclampsia. We use preeclampsia with severe features, preeclampsia without severe features. And the thought is that there's no such thing as mild preeclampsia because it's an unstable condition and it can change at any minute. So we don't want to be deceived into thinking that it's a mild disorder. So if we have someone with gestational hypertension or preeclampsia without severe features, what do we do? Well, we monitor for severe features. So if we have someone with gestational hypertension, preeclampsia without severe features, they can still be monitored outside of the hospital, but we have to have a good surveillance strategy for monitoring for severe features. What is recommended is daily kit counts, twice weekly blood pressure, and the twice weekly blood pressure doesn't have to be a doctor visit, it can be a nurse visit. It's preferred over self-monitoring, but self-monitoring by the patient is an option. Weekly labs, and ACOG recommends platelets and liver enzymes. They feel like those two in particular are probably acceptable in terms of screening. I usually also recommend twice weekly fetal testing if possible, so non-stress testing. And I also recommend creatinine and lactate dehydrogenase. And that's just my preferred panel for preeclampsia. But it seems easy to test those things. But as we know, someone may have gestational hypertension at 29 weeks. And now they have to check their blood pressure twice a week and have labs drawn every week. So that can be difficult in someone that has mild elevation in the blood pressure. So I think the critical part is making sure that someone doesn't have chronic hypertension because we would manage that differently. And that can be difficult. But the critical part here is that if we're going to monitor someone outside of the hospital, we have to make sure that they're compliant with that strategy to avoid complications. And why why do we focus on the differences? Because we manage them differently, and we know that women with severe preeclampsia, we deliver earlier. So severe preeclampsia, 34 weeks. Preeclampsia without severe features, 37 weeks. That's been pretty consistent for a long time. Gestational hypertension, this is a change. The new recommendation is delivery at 37 weeks. Before, really, there was no recommendation before 2013. I often delivered at 39 weeks, 40 weeks, if someone had mild elevation of the blood pressure but did not have preeclampsia. But now ACOG recommends 37 weeks, which some people feel is a little bit early, but it is true that it's the safest thing for maternal health to deliver at 37 weeks. Well, a common consult that I get as maternal fetal specialist is, well, doctor, my patient has gestational hypertension, but her blood pressure is 160 over 110. Urine protein's negative, labs are normal. Should I wait until 37 weeks? And there's no guidelines. Actually, one thing with the new guidelines, there's no specific recommendation for what to do with women with gestational hypertension but severe range blood pressure. I recommend delivery by 34 weeks. If you have a patient that requires IV antihypertensives or has severe range blood pressures, that's a severe condition, so I deliver that group at 34 weeks. But it's provider preference. And what is the data? Why did we choose that 37 weeks for gestational hypertension? It was based on this HIPPITAT study in Lancet that looked at, well, what if we take women with gestational hypertension and we either induce labor right away at 37 weeks, or we wait and see what happens. Well, it's a little bit unfair, right? But if we wait, more things are going to happen than if you deliver right away. And that's what we found, that if you have gestational hypertension and you wait, so expectant management, and you look at how many women get severe blood pressures, and if you wait, 23%, 27%, versus if you deliver right away, it's less. So clearly, if you wait, you're going to get more women with severe range blood pressure, which we consider to be the leading cause of maternal death, and we don't want that to happen. So the conclusion, really looking at that, is we want to deliver sooner. And the neonatal outcome is no different. And that's important because now we are trying to deliver everybody beyond 30, trying to get to 39 weeks. 37 weeks is still considered a little bit early, but at least in this study, there was no difference in neonatal outcome in terms of respiratory distress or risks of delivering early. It seems better to consider maternal health in this situation. And the question is, you get a greater benefit from delivering women with preeclampsia because they're more likely to have complications. But again, even if you separate out gestational hypertension, there's a benefit to early delivery. We'll go there. So, okay, we'll give a little example to kind of break it up. It's a difficult situation because we say the guidelines seem very easy. Okay, this is very straightforward. But it's very complex in the real world. And just a little example of that, because we say deliver preeclampsia with severe features by 34 weeks. Okay, but women come earlier than 34 weeks. So, if you had someone with a blood pressure 150 over 90 and they have a severe persistent headache, when do we deliver and get a consultation? 34 weeks. Okay, sounds good. But this patient is 26 weeks. Okay, now what do we do? Because we can agree that the severe headache is very, very dangerous. But if we deliver at 26 weeks, the condition is very serious for baby. The baby may not survive. So now we have a dilemma. what to do in this case. And we have to make that choice. Okay, so we check labs. The labs are normal, liver enzymes, platelets, urine proteins negative. That helps a little bit. We try medications, right? First goal is to treat the headache. We give Tylenol, we give metoclopramide, promethazine, whatever you like to give. In this particular case, nothing's working. So we've tried our normal agents, but nothing is working. And should we deliver now? Still not clear. I think often we'll get head imaging, right? Because if we're going to deliver someone at 26 weeks, we want to be sure, we want to be certain. So we might get a head CT or a brain MRI. We might look at the veins because we're looking for sagittal vein thrombosis. Well, in this particular case, we did both because we really didn't want to deliver the patient. Still normal. These are normal. So should we deliver now? This question. Tough choices, right? Tough choices. Well, here we'll save you. Okay, so we get notified the blood pressure is 190 over 120. We do an exam and there's hyperreflexia and 3 beats of clonus. So I would think at this point we deliver. But these are the challenges that we face every day. Although we can have guidelines, it's very difficult. I think we'll hear about when to deliver, and that there's numerous examples just like this that are very complex. So again, we heard a little bit about blood pressure management, and I think we may hear a little bit about, when do we decide to deliver. But again, 160 over 110 for 15 minutes is a life-threatening emergency, and that's a key point, I think, from a lot of these talks, is that you really have to treat that blood pressure. You heard a little bit about the choices: labetalol, hydralazine, nifedipine. And I would recommend, if you have someone with a severe blood pressure and you're still pregnant, really magnesium sulfate should be started. I've seen many situations where a patient has a severe blood pressure, they're treated with blood pressure medication, and there's no magnesium sulfate being given. They should really go together because once someone has a severe blood pressure, they're at risk for seizure. They should also be on the fetal heart monitor. I would really stress that if you're treating a patient that's pregnant with IV antihypertensives, they should be on the fetal monitor. And then lab work. So what's the regimen? Just real quick. It's important, to have these handy because there is recommended strategy, I think, based on good evidence. So 20 milligrams, right? 20 milligrams labetalol. Have to repeat the blood pressure in 10 minutes. So the nurse calls, give 20 milligrams of labetalol, and you're going to go work on other patients, and you follow up 45 minutes later. Is that okay? No, it's not okay, right? At 10 minutes. You have to recheck in 10 minutes. And then 40 milligrams. You have to double it. 20 milligrams, 40 milligrams. Check it again. It's not working. 80 milligrams. So 20 milligrams, 40 milligrams, 80 milligrams. And you have to follow this regimen. This is the recommended strategy. If that's not working, go to another agent. Hydralazine is one example. Okay. And so there's recommendations for hydralazine, but I won't go into that here. Nifedipine. I think nifedipine is really a good choice because it's oral, right? You can take a pill. And this is really helpful for women that don't have an IV yet, right? And it acts quickly, and there's data that it acts more quickly than labetalol. So I like nifedipine a lot. And the key is it's different than extended release nifedipine, right? There's a nifedipine that's long acting and there's a nifedipine that's short acting. So one, make sure you're using the right medication, right? Medication error is the #1 source of maternal death as well. So we want to use the immediate release nifedipine. ACOG recommends to swallow it. Some people bite it or put it under the tongue. That's not recommended. They're recommended just to swallow the pill directly. Nifedipine is 10 milligrams, 20 milligrams, 20 milligrams. They give 10 milligrams, not working, 20 milligrams, 20 milligrams. I would try to have these doses memorized is the best if you remember it. Otherwise, now we all have phones. We can put it on our phone and have that handy. So those are all important to recommend. And it's very simple because we have recommendations. But it's true. And every time I do consultations and see patients, most of the time, those doses are not followed correctly. So that's a very critical area that we can improve. The other thing is magnesium. When should we give magnesium? ACOG said, it was a debate, do we give magnesium to everybody with preeclampsia or just women with severe features? And now the recommendation is preeclampsia for women with severe features, but we don't need to give it for those who do not have severe features. And there's still, again, provider preference, but that's the new recommendation. You know, why is that? Well, it does seem to be clear when we look at the big MAGPIE trial, the big randomized control trial of magnesium. If you give magnesium, you get a 60% reduction in eclampsia, seizure, right? So why would we not give magnesium? And there's some debate. I think the debate is that women with more mild disease don't seize as often. So there's some debate. Part of this depends on what your rate of seizure is. Because if you have more women with eclampsia, then you have more reason to give magnesium. So when we looked at the data from this trial, if you look, this is sort of by perinatal mortality. So if you have low perinatal mortality and a low rate of seizure, like in the United States, our rate of seizure is 0.8%, you need to treat nearly 400 women with magnesium to prevent one seizure. And it's just true, like in my institution, we have about 2 or 3 seizures a year. So that means we're given a lot of magnesium, and most often women don't have seizure. But we know that seizure is more common, right? Every country is different, every population is different. And in countries that have high perinatal mortality, the rate of seizure as high as 2.3% in this study. So you only have to treat 66 women to prevent one seizure. And so really, and then if you're moderate perinatal mortality, 125 women. So really, it's just how many women do you need to treat to prevent one seizure? And magnesium is not a fun medication to take, so we have to make that choice carefully. Okay. I think just real quickly, finally, you've gone through all this, you've gone through the delivered the patient, now she's completely better. We used to be able to say, you're fine, you had your preeclampsia, we delivered you. Now I think it's important to counsel women that we now have evidence that there are long-term consequences. What do we mean? That if you have preeclampsia, particularly if you have severe preeclampsia, you have an increased lifelong risk of ischemic heart disease, stroke, venous thromboembolism, and even mortality within 10 to 15 years of diagnosis. And so the risk is 2 to 3-fold increase in risk if you've had preeclampsia versus a pregnancy without preeclampsia. So that's pretty serious, pretty amazing considering that we work with young women who are having babies. But it's something that we have to consider. Go ahead and take this. What is recommended? There's still no clear guidelines. I think this is the next area that we're working on to figure out what do we do, how do we prevent long-term cardiovascular disease. The American Heart Association and the American College of Obstetricians and Gynecologists recommend that, one, they say preeclampsia is a formal risk factor for cardiovascular disease similar to tobacco. They recommend that women should see their primary care provider to follow up blood pressure, weight, fasting glucose, fasting lipids, so cholesterol. I usually say within a year, and then their primary care doctor can determine the amount of follow-up after that. But Many women that we see are young, right, 20s, 30s. They might not see a doctor regularly, so it's important that we advise them if they did have this condition that they should see their primary care doctor. So thank you for your time. To summarize, preeclampsia, the definition has broadened. We now understand that it's a systemic disorder, that proteinuria is still part of the disease but is no longer required. We're monitoring for severe features of disease. The low-dose aspirin, we need to consider that low-dose aspirin in high-risk groups. Magnesium sulfate, optional if we think the risk for seizure is low. And that remember to counsel for long-term risks following the pregnancy. Okay. Thank you.